It's a slightly unusual situation because I'm a professor of ENT and work in an academic hospital. So when I see patients, they have come having failed their treatment by the general practitioners, and that means that I have to give them something additional. So my choice would be either amoxicillin clavulanate or clarithromycin plus metronidazole. I see a lot of patients with chronic rhinosinusitis and with patients with acute on-chronic rhinosinusitis. So I frequently use a macrolide, particularly clarithromycin, not just for its antibiotic properties, but also because of its anti-inflammatory properties. It's been shown to be a very significant immune modulator of disease, and it's carried by the cells, such as white blood cells, to the site of inflammation. So that means that it's a very good drug for delivering its properties to the exact site of the inflammation within the sinus mucosa. It also has both bacteriological properties which are bacteriostatic and at higher concentrations bactericidal. If we look sort of globally at upper respiratory tract infections and divide them up into pharyngitis and tonsillitis, acute otitis media, and obviously acute sinusitis, there are studies which show that clarithromycin works equally as well as penicillins. And so these are generally available and used throughout the UK. In fact, the use of clarithromycin for sinusitis is actually increasing. I think guidelines are really important because we want to try and reduce antibiotic usage globally, particularly to reduce its use in viral conditions, because there is a big resistance problem throughout the world now. So what we want to do is encourage people to wait for the first 3 or 4 days until the symptoms persist or get worse, and that is the point when we want them to start using antibiotics. And actually there have been studies done in this part of the world showing that many GPs and ENT doctors are actually following those guidelines and reserving antibiotics for the more severe cases.